Hi, welcome to IU Radiology Case of the Day. My name is Nick Kuntz. I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I have an interesting head and neck case of the day to present to you. I want to start by saying that all of this educational content has been fully de-identified in order to protect patient privacy. Okay, so this is a case of an adult who presented with sensory neural hearing loss. And I have 4 images for you to take a look at. Image on the top left is an axial contrast enhanced CT in soft tissue algorithm reconstruction. The image on the top right is that same axial contrast enhanced CT, but this time we're looking at it in the bone algorithm reconstruction. The image on the bottom left is an axial T2 weighted fat saturated image, and the image on the bottom right is an axial T1 weighted image. So take just a few moments to look at these images, try to piece together what you think is going on. Okay, I have 2 questions that pertain to this case. The first question is, where is this lesion centered? And second, what's your diagnosis? All right, so let's take a look at the imaging. First up is our axial contrast enhanced CT. And you can see, again, this is done with soft tissue reconstruction. And what should become readily apparent is we're dealing with the petrous apex mass. And this is a mass because it occupies space. It's denoted here with the yellow arrow. And you can see it's a lytic lesion, and it's low density. There's not really any enhancement that's associated with this lesion at all. You can see just a little bit of linear enhancement at the anterior or ventral edge of this. That simply represents partial volume averaging through the petrous segment of the internal carotid artery. So no true contrast enhancement associated with this. Whenever we see a lesion like this, particularly in this location, but really in any location involving, we want to really scrutinize the bone margins. So we can say that this is an expansile lesion. It looks benign. It's got a thin sclerotic rim. As you can see denoted here with the yellow arrow, there are a couple of areas where it's become focally dehiscent, but in general, this is a very benign appearing lesion. It has a sharp zone of transition. You could take a pencil and trace the exact margins of this lesion. Nothing looks permeative or destroyed or chewed up. Looks like something that's been slow growing and slowly remodeling the bone, this benign expansile characteristic. This is a nice case where CT and MRI are certainly complementary in its assessment of the lesion. And so we're looking at our axial T2 weighted sequence. Again, it's a fat saturated sequence, and we can see that this mass is heterogeneously hyperintense. There's a little bit of intrinsic dark signal kind of centrally within it, but for the most part it's a pretty bright lesion, except at its periphery. Right where that arrow is pointing, you can see that there's a T2 dark rim surrounding it. And this is consistent with hemosiderin deposition from remote blood products, remote hemorrhage. Whenever we are looking at a lesion, it's important to take a look at all of the pulse sequences. And so I'm showing you the T1 weighted images, and this is a pre-contrast sequence. We know that because if we look at the nasal, the sinonasal mucosa, it's not bright, it's not enhancing. As the adage goes, the nose knows. So that's always an important thing to take a look at to figure out whether you're dealing with something that's intrinsically T1 bright, which this lesion is, versus something that's enhancing. So it's important, again, to look at all your pulse sequences. Each of them is going to give you the results to a small piece of the puzzle that you can put together. So we can see this is intrinsically T1 bright, really light bulb bright. It's bright as fat. And it has a very thin T1 dark rim surrounding it. You can see the yellow arrow here is pointing right to that dark rim, again representing hemosiderin. This thing has bled at some point in the past, and it's got blood products of different ages. A lot of it's T1 bright, but there is also some of that T1 dark hemosiderin at its periphery. So put it together: benign, expansile, thin sclerotic rim, non-enhancing, low density, intrinsically T1 bright, maybe some blood products within it. What's the diagnosis? This is a cholesterol granuloma involving the temporal bone, specifically the petrous apex. And this is thought to be a foreign body giant cell reaction that results from cholesterol deposition, and there may be some associated fibrosis and vascular proliferation that can be seen at histopathology. It's not really certain what causes this. There's a couple of predominant theories, the first being a vacuum phenomenon in which you have obstruction of these petrous apex air cells, or maybe even eustachian tube dysfunction. And that vacuum phenomenon leads to hemorrhage that causes cholesterol crystals to come out and be deposited. And those incite this inflammatory foreign body giant cell reaction, which causes more bleeding. And over time, that cycle leads to these expansile bone changes with this slow benign osseous remodeling. The other thought is it may have to do with repeated microhemorrhages due to exposed bone marrow. Regardless of what exactly is causing it, it's the same effect. We have this cyclical bleeding, that we have this so-called chocolate cyst of old blood products and lipid material that gets deposited and slowly gets bigger and more expansile. These are oftentimes purely incidental, maybe asymptomatic, but can also present sort of with nonspecific things like headache and dizziness. You may get hearing loss or other cranial neuropathies depending on how big and expansile and what's involved. If patients are symptomatic, these are oftentimes managed surgically, but if purely incidental, watchful waiting is not a bad way to go about addressing these. Certainly you don't want to take an asymptomatic patient and make them symptomatic, but something that does need to be followed because over time they will expand, they will get larger, they may even erode into important structures. As some follow-up reading to this educational content, I'd recommend checking out this great paper by Amy Giuliano and colleagues that was published in Radiology back in 2013. And one of the topics that they cover are cholesterol granulomas involving the temporal bone. So this is a great read for residents and fellows to check out. So let's wrap this up. Again, we're dealing with a temporal bone cholesterol granuloma. The key imaging features to know here would be that this is a non-enhancing and, importantly, expansile mass. We want to see those benign expansile bone changes to make this diagnosis. These will be intrinsically T1 bright. That's likely a combination of these blood products and cholesterol content. And it may be peripherally T2 dark from hemosiderin deposition. Important to keep in mind, the surrounding bone is normal. There's no edema in the adjacent bone. This is a benign actor, and you need to recognize it as such. There's a couple of pitfalls to keep in mind, though. First of all, you don't want to confuse intrinsically bright T1 signal intensity for enhancement. It's really important to check out the nasopharyngeal or the sinonasal mucosa in order to determine whether or not this is truly a pre-contrast or a post-contrast sequence. In this case, it's intrinsically T1 bright and it's not enhancing. So we don't want to confuse it for an enhancing mass. That'll give you a separate differential diagnosis. The other pitfall has to do with overcalling T1 bright fluid that's in the petrous apex. That does not typically represent a cholesterol granuloma. You really need to see those benign expansile bone changes. I would say that on a daily basis, we encounter patients that have, to some degree, T1 bright fluid trapped within their petrous apex. This may just be due to having sort of proteinaceous or inspissated secretions within aerated petrous apex cells. You certainly don't want to make the mistake and call those as a cholesterol granuloma because we don't want those patients to go to surgery only to find out afterward that, oops, it wasn't really a cholesterol granuloma. And again, I want to stress, use those benign expansile bone changes to make this diagnosis. In fact, you can use it to try to narrow down your differential diagnosis of a T1 bright posterior petrous ridge lesion, such as an endolymphatic sac tumor, because those will have much more aggressive bone changes, maybe even have some eggshell calcification associated with it. But this has very characteristic benign, circumscribed, expansile bone changes, really the take-home point in this case. All right, well, thanks for tuning in to IU Radiology Case of the Day. I would invite you to follow along with this on Twitter at NAKuntz, as well as to check out our collection of IU Radiology Case of the Day materials, which can be found at radtf.iuhealth.org/COTD. Thanks so much.